Welcome to AETCM channel. Today we will see how to manage a pulseless electrical activity cardiac arrest. Let's come to the scenario. This is a 68-year-old male patient, known case of COPD. He was admitted in hospital due to severe breathing difficulty, and he was admitted in the ward with a BiPAP support because of increased respiratory distress and all. He was found unresponsive in the morning, and we can see a ward staff is coming to check the patient. So the staff has come and checked the patient for any response. He is not having any response.
Calling for help.
He is calling for help.
Then checking for pulse and respirations.
He has checked for central carotid pulse and respiratory efforts. He maximum 10 seconds only should be given for assessment of pulse. He haven't got any pulse, so he is starting CPR. So since help was called, code blue was paged in the hospital, and our advanced cardiac arrest resuscitation team is informed. Our cardiac arrest resuscitation team has arrived on the scene. Let's see how the team will manage this cardiac arrest.
Dr. Vivek, you can do the CPR. Dr. Manna, you can take care of the airway. Give rescue breaths every 2 rescue breaths for every 30 compressions. Dr. Riaz, you can get a IV access and load the drugs. Dr. Binu, you can document, and Sabha, please connect the monitors.
30. IV cannula secured.
So rescue breaths are given for over 1 second, assessing the chest rise to see whether chest wall movements are there with the rescue breath. If chest wall movements are reduced, we can do a chin lift, head
Stop
lift
CPR.
maneuver.
We can assess the rhythm. Please check the electrode placement. It is showing asystole. Please continue CPR. And
you can check each leads to any change in rhythm is there? Yes. Once cycle through the leads,
30.
now I think we are getting a rhythm.
Please stop CPR. We will assess the rhythm.
We are getting a rhythm now.
Please check the pulse. It is an organized rhythm.
Central pulse is absent.
Continue CPR. It is a PEA, and give epinephrine 1 mg, 1 in 10,000 dilution.
Epinephrine 10 ml, 1 in 10,000 dilution, 1 mg epinephrine given, followed by 20 ml saline flush given.
Do.
Dr. Riaz can get a ABG also.
Sure.
Since it is a PEA cardiac arrest, advanced airway placement can be done initially itself.
Dr. Manna can place an advanced airway and go for capnography monitoring.
Advanced airway can either be a cuffed ET tube but done by direct intubation, visualized intubation, or can be a supraglottic airway device like a laryngeal mask airway inserted.
Okay, 2 minutes over.
Stop CPR, reassess the rhythm. It is showing organized rhythm. Check for pulse. In less than 10 seconds.
No pulse.
It's a PEA, continue CPR. And advanced airway has been achieved. So give breaths every 6 seconds. And epinephrine should be given once in 3 minutes.
Second dose of epinephrine given, 1 in 10,000 dilution, 10 ml, 1 mg of epinephrine given, followed by 20 ml saline flush also given.
We can by the time if there is any correctable cause, we have to look for. So we have already asked for the ABG. Then we can check for other causes like any cardiac thrombi, pulmonary thrombi, and we can go for like if there's any hyperkalemia, hypokalemia, then any hypothermia history, or any history of any toxin ingestion, or if it is a pneumothorax, cardiac tamponade and all, we can look for. So we have to get a history, so we can ask one person to get a history, and we can also get the help of a point of care ultrasound or echo in between the arrests.
So the 5H and 5Ts has to be ruled out, and for that we can do a blood side arterial blood gas analysis to assess for any acidosis, PCO2 status of the patient. If the patient is persisting to be in cardiac arrest, a bedside point of care echo can be done to assess any cardiac tamponade is there, any whether cardiac MI, myocardial infarction is there, and breath sounds can be assessed to any decreased air entry after intubating the patient to check for any pneumothorax, right? Fine.
2 minutes over.
Please stop CPR. We'll assess the rhythm. Showing a organized rhythm, please check for pulse.
Central pulse is absent.
Continue CPR.
3 dose of epinephrine, 1 in 10,000 diluted 10 ml given, followed by 20 ml saline first given.
So we have already achieved the advanced airway and going for ETCO2 monitoring. ETCO2 is showing like 30, so it is a good quality CPR.
Alright, ABG has arrived. ABG is showing a pH of 6.9, PCO2 is around 108, and PO2 is only 20. Lactate is around 15%.
So it is a acidosis is there with hypoxia.
Bicarb is hardly told.
So hypoxia we have corrected with advanced airway placement. For the acidosis we can give 50 milliequivalents of bicarbonate IV stat, and we can also start the patient on IV fluid bolus of 20 ml per kg. Dr. Riaz, please administrate.
So the ABG was showing severe type 2 respiratory acidosis and metabolic acidosis with lactate of 15 and bicarb of 8. PCO2 was more than 100. PCO2 correction is being done by the advanced airway placement and good quality ventilation. For metabolic acidosis improvement, we have given sodium bicarb injection as well as IV fluids to correct if hypotension is the cause of lactic acidosis. Now the CPR has been ongoing for last 30 minutes. The patient's rhythm haven't changed from pulseless electrical activity. We have given all the drugs for correcting the acidosis, but till now failed to revive the rhythm.
Okay, 2 minutes over.
Please stop CPR. Rhythm assessment. Rhythm is showing a sinus tachycardia. So please check for pulse.
Central pulse is present.
So central pulse present. We have attained return of spontaneous circulation, and we can go for post cardiac arrest care.
So the ROSC is achieved in this case and the cardiac arrest has been managed.